Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture series, we're going to go through nearly everything in the nursing pharmacology curriculum. Whether you're here as a nurse practitioner, getting ready for the NCLEX, or anything else, I hope that you enjoy this series. All the notes that are used in this lecture series are available on our website at bulletpointnursing.com. Let's begin talking about anticoagulation with a really brief pathophysiology review. When there's a compromised blood vessel, when a patient starts to bleed, the first responders, the ones that get there the quickest and begin the process of preventing blood loss, are platelets. Platelets aggregate is the term that we use. They aggregate and they form a beginning of a clot. Then they are reinforced with fibrin. Fibrin is the end result of the coagulation cascade. You do not need to understand the full coagulation pathway to understand the pharmacology, but understand that the end product is fibrin. Fibrin forms a fibrin plug, which reinforces the platelets and forms the definitive clot. Now, when the body is done with this clot, the body has a mechanism to get rid of it, and that mechanism is called plasmin. Plasmin is the only substance that we deal with that actually breaks down and destroys clots. Now, we're going to start to talk a little bit about pharmacology. We divide the drugs that we're going to be talking about, the drugs that interfere with the clotting process, into anticoagulants and antiplatelets, because each of these are distinct in that they each interfere with different parts of the coagulation process. One deals with the coagulation pathway, one deals with platelets. So most of the drugs that we're going to be talking about, at least in the first half when we talk about anticoagulants, have reversal agents so that if a patient starts to bleed in excess, we can reverse the process of them being anticoagulated. If a patient requires help with clotting, but they are not on a drug that we can readily reverse, what we use is plasma. Everyone knows that whole blood, when we donate blood or when we deal with blood as a nurse, we have whole blood, and that can be broken down into FFP, fresh frozen plasma, PRBCs, and other things. Plasma is what contains our clotting cascade, and or our clotting factors. And that's important to know because when we don't have reversal agents, that's often our go-to to help a patient clot. The next few items, I don't have anything to expand on that. All the anticoagulants increase your risk of bleeding. Of course, that sounds obvious, but make sure you understand that. Some of these drugs may be prescribed with a PPI in order to reduce your risk of GI bleeding. And almost all anticoagulants and antiplatelets should be stopped prior to surgery. If you're here as a nurse practitioner student, please note you probably do need to know the exact time frame for when each of these drugs should be stopped. It ranges from 24 hours to 7 days of how long they should be stopped before surgery. And we want to be really precise because if a patient's on an anticoagulant or an antiplatelet, it's for a reason. And we want to keep that effect going on. But we do need to stop it for surgery. So we want to stop it at the exact minimum so that the patient gets the most benefit out of their medication, but stops it before it would cause a problem with surgery. Again, some of them need to be stopped just 1 day before, some of them up to 7 days before. At the RN level, you probably don't have to know that, but just know that it is in that range. Patients that are on anticoagulants, and we're using it now loosely, including antiplatelets, should be placed on bleeding precautions, such as no extra IV sticks, don't use a straight blade for shaving them, use an electric shaver, things like that. Now, it is a favorite test question to ask about what interferes or what interactions we have with anticoagulants. And one of the more famous ones is that many CAMs, specifically the ones that start with G, garlic, ginger, ginkgo, most of those do interfere with a lot of different anticoagulants. So just know that if a patient's on one of those, you want to get them off of it. Many patients with an arrhythmia may be placed on an anticoagulant, and that's to prevent them from developing clots. We're going to talk more about that in the very next lecture when we talk about heart failure and dysrhythmias, but just let's leave it at that for now. So the first drug we're going to talk about is heparin. Heparin, depending on what textbook you're using, may be classified as an anticoagulant and considered that drug class. Sometimes it may be considered an indirect thrombin inhibitor because that is its MOA, or your book may just call it good old heparin. So the mechanism of action is that it inactivates thrombin and it prevents the conversion of fibrinogen to fibrin. All of that means that it prevents the coagulation pathway from getting us that end result of fibrin, thereby preventing us from properly clotting. What do we use this for? We use it for the treatment and prevention of thromboembolic events, aka clots, such as DVTs, PEs, etc. Now it says treatment and prevention. Keep in mind, treatment refers to the active phase of a patient having a DVT or a PE, versus prevention is where, let's say a patient has AFib or something like that, or a patient's having a heart attack and we want to prevent further clots. This medication, like all medications except one, do not break down clots. These anticoagulants do not break down clots. They prevent further clots. And we use it for that prevention or for the treatment of a patient who is having a problem with clots, but not to break down the clot, just to prevent it from getting worse and to prevent future ones from developing. It makes sense. If a patient already has a clot, they're at risk for further clots. This medication is IV only, or I'm sorry, parenterally only, so it's not available PO. Adverse effects is hemorrhage. Obviously, almost everything in this lecture has an adverse effect of hemorrhage. This medication also has something called heparin-induced thrombocytopenia, which is where we do not have enough platelets. And if a patient develops that, we switch them to another medication, a different anticoagulant. This medication does have a reversal agent, as fortunately most of the drugs we're going to talk about do, and it is reversed with protamine sulfate. When a patient is on any anticoagulant, you're going to have to know what labs we need to monitor in that patient, whether you're as a nurse or a nurse practitioner. And in the case of heparin, it's going to be the PTT, APTT, and factor 10A. So know that those three labs are what we use to monitor for a patient that's taking heparin. Heparin is not dosed in milligrams, it's dosed in units, so I would know that. The onset is 20 to 30 minutes, very quick, and you're going to see that contrast with a lot of other anticoagulants. So when we want a really quick onset of anticoagulation, this is usually our go-to. This does not cross the fetal placental barrier, and it is considered safe in pregnancy, in contrast to warfarin, which is absolutely a no-go in pregnancy. Heparin, you may also see it referred to as UFH, or unfractionated heparin. Another drug that we have in this same class, if we're not calling heparin a class, another drug would be enoxaparin, which is known as Lovenox. This is also referred to as a LMWH, or low molecular weight heparin. This medication works nearly the same way as heparin. However, it has a few differences. First of all, this medication has less instance of causing HIT. If a patient has a history of heparin-induced thrombocytopenia, we're probably not going to give them heparin again, but we can still give them enoxaparin. Also, this medication takes several hours to work versus heparin kicks in, we said, in 20 to 30 minutes. Low molecular weight heparin or enoxaparin is generally considered simpler to use. So if a patient, for example, is on DVT prophylaxis, let's say they're going to be in the hospital bedridden for a while, and we know that when people sit around and clot, so in the hospital, we're going to do DVT prophylaxis. We're going to do things to prevent the patient from developing a DVT. We're much more likely to use enoxaparin for that versus heparin, at least in most parts of the country. The next drug class we're going to talk about is a vitamin K antagonist, and that is warfarin. Mechanism of action, exactly like the drug class sounds. It is a vitamin K antagonist. What is it used for? It is used for, again, the treatment and prevention of thromboembolic events, so the exact same thing. The onset here, you'll note, is 1 to 3 days, 24 to 72 hours. And the big deal here is that if I want immediate anticoagulation, this is not an option. I have to go to heparin. However, very often we start a patient on heparin, and then we may continue their anticoagulation with vitamin K. In that case, when we transition from heparin to warfarin, we do need to overlap the two because we don't want the patient to have any lapse in coverage, so to speak, where they're not properly anticoagulated. So we'll start them on heparin and warfarin, and then in 1 to 2 to 3 days, when the warfarin kicks in, we can get them off of the heparin. Warfarin is an oral agent as opposed to heparin and low molecular weight heparin, which are both parenterally only. This one is monitored via PT and an INR. These labs must be regularly assessed. And again, this is something that patients go home on. Heparin is not. This is something that a patient can go home on. So we do need to regularly have them check in to get their labs monitored, specifically the INR. A normal INR is below is at 1.1 or below. When a patient is on warfarin, in order to show that the warfarin is therapeutic, that it's properly anticoagulating them, we want the INR to be at 2 to 3. Okay, some books may have a slight variation on that, but generally 2 to 3 is the correct answer. This medication is contraindicated in pregnancy. It is reversed with vitamin K, so this does also have a reversal agent. Warfarin is infamous for interacting with tons of other medications. If you've been watching our lecture series, you learned that MAOI, such as phenelzine, are also infamous for interacting with a ton of medications. Warfarin is right up there as well. There's a lot of medications it interacts with. One of the most common areas where we get ourselves into trouble is with antibiotics, because a lot of antibiotics will increase the effects of warfarin, so that when we put the patient who's already on warfarin on an antibiotic, if we're not paying attention, we can end up with an INR 6, 7, 8, 9, 10, where the patient is just a paper cut away from bleeding to death. Finally, patients should be educated that while they're on this medication, whatever their normal dietary intake of vitamin K is, that should not suddenly change. You may also be asked, what are sources of vitamin K? Dark green leafy vegetables and plenty more, but you should educate your patient to not suddenly increase their intake of it, or else it could be counteracting the medication. The next drug class we have are DTIs, or direct thrombin inhibitors. The big drug in this class is dabigatran, or Pradaxa. The mechanism of action here is, again, exactly like the drug class sounds. It's a DTI. It directly inhibits thrombin. The indications for this, again, are the same as we talked previously in a patient that's having a DVT or a PE, or a patient long-term for the prevention of AFib. The big adverse effect over here is GI upset. Again, obviously, all of these have the adverse effect of causing bleeding. This does have a black box warning that you should not suddenly stop taking it, or it can cause clotting. That makes sense. If a patient's body has been properly anticoagulated, especially if it's been that way for a period of time, if I suddenly stop taking it, I have a dramatically increased risk of developing thromboembolic events, aka blood clots. That's why it's a black box warning. This medication does have a reversal agent. The reversal agent is actually a monoclonal antibody, which is an interesting drug class that we haven't covered in depth yet. I don't even know how to pronounce that, so I'm going to go with the brand name, which is Praxibine. This medication, the DTIs, are also referred to as DOACs. DOAC, or direct oral anticoagulant, is this, and the next drug class as well are referred to as DOACs. Just if you ever see that term, know what it is. There is another drug in this class, a DTI, direct thrombin inhibitor, is argatroban. Argatroban, however, is sort of a subset of this class because this is different than dabigatran. This medication is definitely not a DOAC because it's not oral, it's IV only. The big claim to fame of argatroban is that in many guidelines and protocols, argatroban is our go-to anticoagulant if a patient develops HIT, heparin-induced thrombocytopenia. The next drug class we have is the last anticoagulant we're going to discuss, and that is factor Xa inhibitors. You've undoubtedly seen commercials for these two drugs, Xarelto and Eliquis. They're heavily marketed. The generic name here is rivaroxaban and apixaban. There are a few others in this class. I just listed the top two. The mechanism of action, again, like the drug class sounds, inhibits factor Xa, which is part of the coagulation pathway, which gets us the interfering with the end result of fibrin, so we don't get fibrin. The indication for this, same as everything else we've talked about. We give it for patient experiencing a DVT or a PE, and for the prevention of clots in a patient that has AFib. This does have the same black box warning as the last one, that an abrupt discontinuation can cause clots, and this is also referred to as a DOAC. These drugs do have a reversal agent, and that is factor Xa. Again, that makes sense. If it's a factor Xa inhibitor, if I give you factor Xa, then I'm able to reverse it. The next drug we have is a antiplatelet, first antiplatelet that we're going to talk about, and the drug is aspirin. You should recognize this from way back when, or I think our second lecture, where we talked about NSAIDs. This drug is an NSAID, aspirin, acetylsalicylic acid. The mechanism of action is that it inhibits COX, which causes suppression of platelet aggregation. This is the only NSAID that causes that inhibition of platelet aggregation. The indications for this are prevention of thrombotic events, such as a heart attack, stroke, and so on. Please note that this medication permanently inactivates platelets. Every platelet has a lifespan of roughly 7 to 10 days. Any platelet that's been affected by aspirin is permanently out of commission. So there's no reversal agent for this. The adverse effects are increased risk of GI bleeding. If you watch the lecture that I was referencing, we know that NSAIDs all have that famous black box warning that they cause an increased risk of GI bleeding. And that's related to the actions of COX-1. This medication is also obviously discussed separately. This medication is the only NSAID, again, that's considered an antiplatelet. The next antiplatelet we have are the G2B3A inhibitors. And if you say that really quick, you sound smart, but I'm just kidding. The medication class is glycoprotein 2B3A inhibitors. The drug here is tirofavin or aggrastat. This medication is also IV only. This is another antiplatelet. Once again, we're using it for the prevention of clots. This one is almost only used in patients that are having a heart attack. Since you are still here watching and hopefully enjoying this video and this lecture series, please go ahead and subscribe to our channel. All of the content that's available on this channel is 100% free. The only thing that we ask is that you please go ahead and hit that subscribe button to support us. Next, we have the drug class of ADP receptor antagonists, and this is also another antiplatelet. The drugs here are clopidogrel, ticagrelor, and some others. You're probably familiar with the brand names here, which are Plavix and Brilinta. These medications work, once again, by the way the drug class sounds, blocking ADP receptors, which causes a reduction in platelet aggregation. What do we use this for? We use it for a lot of different things. Most commonly, this medication is used in almost universally in protocols of patients that are having a heart attack, that we give this to the patient almost immediately upon diagnosing a heart attack, and then we continue it for some period of time, 30 to 90 days, something like that, depending on what the guideline says and what protocol you're following. But almost all patients that have a heart attack in the US do get one of these two medications, the Plavix or the Brilinta. This medication can be given with aspirin. We rarely, if ever, double up on anticoagulants unless we're trying to overlap something. However, antiplatelets, we do sometimes double up. Classic example, a patient can be on both Plavix and aspirin. That is part of a lot of different guidelines. This medication does have a rare adverse effect, and that is TTP, or thrombotic thrombocytopenic purpura. If a patient develops this, it would get us to get them off of that medication. And again, this is another antiplatelet. The next drug we have, depending on what textbook you look at, whether it's going to be listed here or somewhere else in the textbook, because this is also a vasodilator. This next drug, cholesterol or silestazol, I'm not 100% sure. The mechanism of action is that it reduces platelet aggregation, just like aspirin, and it also causes vasodilation. We're switched gears here a little bit because this medication is used for intermittent claudication. Intermittent claudication is where a patient has an issue with their perfusion based on whether they're at rest or whether they're active. And this medication, between the reduction of platelet aggregation and the vasodilation, is something that we use to address that. This isn't a very common medication. We're not going to go real deep into it. Do know it has a black box warning that it's contraindicated in patients with heart failure. The next drug class we're going to talk about are thrombolytics. Thrombolytics are really famous. They came out about 25, 30 years ago, considered almost to be a miracle drug, because this is the only drug that we have, the only drug class that we have that can actually break up a clot. So if a patient's having a clot, standard practice, we take it to the cath lab. Obviously, if it's in the heart, we take them to the neuro lab. If it's in the brain, if they're having a stroke. But we had to do these really intensive procedures that take tons of resources and aren't available everywhere, as opposed to a drug that generally is available even in the most rural hospital. So this drug is designed to specifically break down a clot. It's a thrombolytic, and it works by initiating fibrinolysis, which is the breakdown of fibrin. We talked again at the beginning, fibrin is the foundation of a clot, as opposed to plasmin, which breaks down clots. This activates plasmin. That's what this does. In fact, one of the drugs in this class is called TPA, which stands for tissue plasminogen activator. So the drugs that we have here are alteplase, reteplase, tenecteplase, and there's another one, retaplase. The indications are AMI, CVA, and PE, so a heart attack, stroke, or pulmonary embolism. This is a very serious medication. Universally, anytime you give this medication, you'll be running through a safety checklist to make sure the patient hasn't had a recent trauma, recent surgery, no risk of a bleed. Usually we're going to check their sugar if we're giving this for a stroke to make sure that it's not a problem with their sugar, that they're actually having a stroke. So there's usually a very detailed checklist. Their blood pressure has to be a certain range, their age, that's sort of shifting with the guidelines, but there may be an age limit with giving this. So there's a whole lot that we go into with giving this, because this does systemically break down every clot in your body, and that can put you at really, really, really high risk of bleeding. I don't remember the exact latest stats, but it's something I think like 6% of patients that get this can develop actually brain hemorrhage due to this medication. Obviously, that's a pretty low number. If I'm remembering correctly, don't hold me to it, but that is something to consider. And because of how detrimental that can be, we're really cautious with this medication. This medication is obviously IV only. It is a high-risk medication. It's only given in something like an ER or an ICU or some other high acuity setting. It is usually given with a loading dose. There's a certain percentage that we give first to the patient, then we give the rest over the course of an hour, depending on what the guideline is. When you're giving this medication, these patients usually are going to be a one-on-one as a nurse that you're going to be monitoring just this patient, again, because of how high risk this is, and because if any adverse effects develop, such as signs of intracranial bleeding or some other bleeding, we want the nurse to immediately be able to identify that. The adverse effects of this medication I already referenced is intracranial hemorrhage. This is the only drug class that can actually break down a clot. Everything else just prevents further clots. We already talked about the checklist. One interesting thing about this medication is that we want to avoid extra cannulation of accessing a patient's arteries and veins or any invasive procedure during the time that this medication is in effect because of the extremely high risk of bleeding. More importantly, the extremely high risk of a patient not being able to clot regardless of what we do. Finally, this medication does have a reversal agent, and that is cryoprecipitate. The next medication we're going to talk about is taking a complete 180. This medication is talking about how to help a person clot. So a hemostatic or antifibrinolytic, that's a double negative. Fibrinolytic breaks down fibrin, and antifibrinolytic preserves fibrin. Fibrin, again, is the clot. So this medication is the opposite of everything we're going to talk about. This is helping you clot. The drugs we're talking about here, aminocaproic acid and tranexamic acid, both of these are used to help a patient clot. When do we use this? Obviously, when a patient has a problem with bleeding. How does it work? It inhibits fibrinolysis, and it inhibits plasmin. Plasmin, again, is what breaks down clots. So this prevents that breakdown of clots. The indication for this is for bleeding. What type of bleeding? Most commonly, we use this for excessive vaginal bleeding, either related to some abnormal physiology or related just to menstruation or something like that. And we do use this a lot in trauma, and a lot of the major trauma centers in the US today, as of mid-2023, this is considered part of the guidelines. Thank you so much for watching. Here are your references. Have a great day.